Alright, we'll pick up with acute peripheral arterial occlusion. These acute arterial occlusions are typically sudden. The emboli are the most common causes. Occlusion is more common in the lower extremities. The 6 P's are often the symptoms associated with acute peripheral arterial occlusions. Those 6 P's are pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermy, or coolness. Treatment must be prompt, and anticoagulant therapy should be initiated. Surgical thrombectomies can be performed to remove the occlusion. It's important to remember after these surgeries, you should observe the affected area for improvement in color, temperature, and pulse every hour for the first 24 hours. It's important to monitor for symptoms of a pulmonary embolus, which include chest pain, dyspnea, and acute confusion. Compartment syndrome can occur and occurs when tissue pressure within a space becomes elevated and restricts blood flow. Ischemia can cause tissue damage and tissue death. Increasing pain and swelling should be monitored. Fasciotomy is performed to prevent injury for these patients. Systemic thrombolytic therapy can be initiated. During the infusion, it's important to monitor the patient for bleeding. It's important to maintain a normal blood pressure to prevent stroke. As the clot resolves, the patient commonly experiences pain. Aneurysms of central arteries. Aneurysms are permanent, localized dilations of the artery that cause the artery to enlarge to 2 times its normal diameter. Fusiform is a term used that means diffuse dilation affecting the entire circumference of the artery, and saccular meaning affecting only a certain portion of the artery. Aneurysms can be described as true or false. In true aneurysms, the arterial walls are weakened by congenital problems. With false aneurysms, there is an injury to all 3 layers of the arterial wall. Dissecting aneurysms differ from aneurysms in that they form when blood accumulates in the wall of an artery. Elevated blood pressure can increase the rate of aneurysmal enlargement and risk for early rupture. When dissecting aneurysms occur, the aneurysm enlarges, blood is lost, and blood flow to organs is diminished. Abdominal aortic aneurysms, or AAA, are commonly asymptomatic and they frequently rupture. They are located between the renal arteries and the aortic bifurcation. Thoracic aortic aneurysms, or TAA, they are frequently misdiagnosed and they're not as common as abdominal aortic aneurysms. They are discovered when advanced imaging is used to assess another condition. They develop between the left subclavian artery and the diaphragm. They can also occur in the aortic arch and are very difficult to manage surgically. Aneurysms cause symptoms by exerting pressure on surrounding structures or by rupturing. Rupture is the most common complication and is life-threatening because of shock. Atherosclerosis is a common cause of aneurysms, with hypertension, hyperlipidemia, and cigarette smoking also being factors. Age, gender, and family history are factors, as well as syphilis infection, Marfan syndrome, and rare genetic disorders can cause abdominal aortic aneurysms. Chronic inflammation and blunt trauma can cause thoracic aortic aneurysms. Patients with a known abdominal aortic aneurysm, we should assess for abdominal, flank, or back pain. Pain is unaffected by movement and lasts for several hours or days. A pulsation in the upper abdomen to the left of the midline between the xiphoid process and the umbilicus can be present. A detectable aneurysm is at least 5 centimeters. You can auscultate over the mass, but do not palpate the mass. The patient can have a severe pain of sudden onset in the back or lower abdomen, and it can radiate to the groin or buttocks, and that's typically significant of a ruptured aneurysm. Other clinical manifestations: hypotension, diaphoresis, decreased level of consciousness, oliguria, loss of pulses distal to the rupture, and dysrhythmias. With thoracic aortic aneurysms, the patient often experiences shortness of breath, hoarseness, and difficulty swallowing. Hypovolemic shock can occur in both abdominal aortic aneurysms and thoracic aortic aneurysms. CT scanning with contrast is used for assessing the aneurysm. Ultrasonography can also be used. We want to make sure that we're monitoring the growth and maintaining blood pressure in patients with aneurysms because we want to decrease the risk for rupture. Surgical treatment can be elective or an emergency. For a ruptured abdominal aortic aneurysm, surgery is performed. Activity restrictions should be provided. The patient should not do any heavy lifting, as your book states, of more than 15 to 20 pounds. Aneurysms of the peripheral arteries can occur as well. Peripheral venous disease. VTE, or venous thromboembolism. Two subcategories of VTE are DVT, which is deep vein thrombosis, and PE, which is pulmonary embolism. It's important to remember that pulmonary embolism, we typically see shortness of breath, chest pain, and acute confusion in older adults. A thrombus is a stationary blood clot. An embolus is a moving blood clot. Thrombophlebitis refers to a thrombus that is associated with inflammation. Thrombophlebitis can occur in superficial veins, but they're most commonly in deep veins. Phlebothrombosis is a thrombus without inflammation. DVT is the most common type of thrombophlebitis. Patients that have DVTs are at a greater risk for PEs, and that's when a dislodged clot travels to the pulmonary artery. Thrombus formation is associated with Virchow's triad. Virchow's triad involves the stasis of blood flow, endothelial injury, and/or hypercoagulability. What puts a patient at risk for blood clot formation? Hip surgeries, knee surgeries, or prostate surgeries. And think about why that is. Oral contraceptives, immobility, heart failure, or those sitting for long periods of time are also at risk for blood clot formation. Phlebitis, which is vein inflammation, can predispose patients to thrombus formation. Anyone that is admitted into the hospital is considered moderate to high risk. We want to make sure that we are ambulating these patients, they're getting enough hydration, that we are applying compression stockings, and we're going to make sure that we have a sequential compression device, or SCD, order. Classic signs of a VTE: typically calf or groin tenderness and pain of sudden onset, unilateral swelling of the leg. Warmth, edema, and redness are associated. Homan's sign is when there is pain with dorsiflexion of the foot, This is contraindicated in known DVT patients, and Homan sign is not reliable. This should not be chosen to perform on the patient. We can also measure circumference of the affected leg versus the unaffected leg. Ultrasonography for testing, we can do that for testing for VTEs. D-dimers can be tested because the D-dimer is a marker for coagulation and measures clot breakdown. I will pick up with interventions for peripheral venous disease, and I will talk a little bit about venous insufficiency in the next audio.